Hello, and welcome to Biliary Atresia Educational Webinar. I am Farah Douglas, President and CEO of the Liver Health Foundation. Biliary atresia is probably one of the best-known rare liver diseases simply because of its impact on infants and their parents. I cannot tell you how many stories we have heard about the shock that the parents of newborns experience when they are told that their few days or a few weeks or a few months old baby has a liver disease. It is horrifying for parents. They had never heard of biliary atresia. They had never even thought about liver disease. In tonight's program, we will hear from our medical experts about biliary atresia, its causes, diagnosis, treatments, including Kasai procedure, and more. Liver Health Foundation is proud to host these free educational webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with the mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, San Gabriel Valley, and adjacent cities. In tonight's webinar, Dr. Keith Hazelton will offer a comprehensive review of biliary atresia through a PowerPoint presentation. At the conclusion of the presentation, we will begin a roundtable discussion with Dr. Jocelyn Singh and Dr. Hazelton. And during this roundtable discussion, they will talk about their own experiences in working with BA patients and their research about this disease. If you have any questions, please use Q&A or chat function and post your questions. Our experts will try to respond to questions. Now the disclaimer. Please remember, information given by our experts is not a substitute for advice given by your own physician or healthcare provider. This program has been made possible by an educational grant from Epson Pharmaceuticals. We thank Epson for their support. It is my privilege to introduce Dr. Keith Hazelton, who has generously agreed to be the presenter for tonight's program. Keith Hazelton, MD, PhD, is the attending physician of pediatric gastroenterology, hepatology, and nutrition, and assistant professor of clinical pediatrics at Keck School of Medicine of USC. He received his MD and his PhD from the Albert Einstein College of Medicine and completed his pediatric specialty training at the Children's Hospital, Colorado, University of Colorado. He has joined the liver and intestinal transplant team at CHLA and is a researcher at the Saban Research Institute. Dr. Hazelton's research has focused on how what we eat can affect the intestinal infection caused by C. difficile. As part of Dr. Catherine Luzepan's lab at the University of Colorado. His work has shown that dietary fat and fiber can affect the severity of infection. This finding led to a clinical trial using a low-fat, high-fiber diet to prevent C. difficile infection. His work is currently funded by the National Institute of Health and has previously received funding from the Cystic Fibrosis Foundation. Dr. Hazelton, welcome. We are grateful to have you with us. Thank you for your support and participation. We are ready for your presentation.
Okay. Well, thank you. Thank you for that kind introduction. Let's see. All right, okay. All right, so as Ms. Douglas stated, I'll be going over biliary atresia. Thanks for everyone that sent in questions beforehand. I was able to adjust my slides a little bit to try and answer some of those questions. So I'll get started today. First, just I don't have any relevant financial disclosures for this talk. So what we're going to talk about, I kind of broke this talk up into three parts. going to talk about some background, talk about how we're doing with this particular condition, and how can we do better. So we'll first start with our background. So what is biliary atresia? I'll use some medical words, but I'll try and explain them. So biliary atresia is what we call a fibro-obliterative disease of what's called the extrahepatic bile ducts. So fibro just meaning scarring, obliterative means it makes it go away. So it scars the bile ducts. So the bile ducts, as you can see, are the tubes that carry the bile out of the liver and into the intestines. So it's a disease where these bile ducts go away. So because of that, bile can't get out of the liver, and that leads to scarring of the liver, significant liver damage, and a lot of problems. So before there were any treatments, which were developed in the 50s and the 60s, 1950s and 60s, this condition was unfortunately was 100% fatal by 2 years of age. Um, I'll talk a little bit more about the causes later, but based on kind of newer data over the last decade or two, we believe that this is a condition that starts either during pregnancy or right at birth, or kind of a combination of two that transition from being inside the uterus to outside. And then as Ms. Douglas alluded to, the impact that biliary atresia has in spite of its rarity, it is the #1 indication for liver transplant among children. It's accounts for about 30% of all pediatric liver transplants done. So that's about 150 to 200 every year. Someone has a liver transplant for biliary atresia in this country. So what are our symptoms? So the hard part about this condition is that at birth, a lot of times it's actually fairly, it's not symptomatic. A lot of times kids with biliary atresia are happy, healthy babies, and they have big rolls, and they're eating well, and they look really great. But what happens over time is the bilirubin or the bile both build up in their system because the tubes that carry the bile out of the liver, they're destroyed, and so there's nowhere for the bile to go, and that leads to jaundice. And so that's the yellowing of the skin or of the eyes. What makes this disease particularly hard is a lot of babies get jaundice for a variety of reasons, and biliary atresia is one of the least common causes, but it's probably the most serious. The big thing that we look for as pediatric liver doctors is our telltale sign is pale stools. It's really hard because in us grown adults, generally our poops are brown, but babies, they really shouldn't be. They should have lots of what we call pigment in them, and they should either be bright yellow, this orange, or this bottom row, basically the numbers 4, 5, and 6. These are normal baby poops. What we worry about is the top row, 1, 2, and 3. That's a worrisome color for a baby stool. And so just because it's brown doesn't mean it's good. You really want, it should look like baby poop should look like mustard. Okay, so those are our symptoms. So there's a couple types of biliary atresia. By far the most common type is what we call isolated biliary atresia. That's where it's just problems with the bile ducts in the liver. That accounts for, in the United States and Western Europe, about 85 to 90% of cases. In the East Asian countries, it's actually 95 to 97% of cases. I saw there was a question about the different types of BA. And so the other type is what we call biliary atresia with splenic malformations. And that accounts for anywhere from 3% to 15%, depending on where in the world. So much less common. Unfortunately, it tends to be a more aggressive disease, and it's requiring transplant usually earlier in life. So what is BA with splenic malformations? So splenic malformations, it's interesting. You can either have no spleen or you can have lots of spleens. You're only supposed to have one. The spleen is an organ in the left upper side of your abdomen that's connected to your liver. And so it would make sense that if there's a problem with the liver, maybe you'll have problems with things that are connected to it. Many times this condition actually has other problems with the organs in the abdomen. And so you can have, or actually in the chest as well, in the torso. So you can have a lot of cardiac abnormalities. So congenital heart disease is very common with BA with splenic malformations. You can also have problems with kind of how everything's put together inside your body. And the medical term for that is situs inversus, and that means reverse side. And so things that are on your left side might be on your right side and vice versa, or sometimes everything's just kind of smushed in the middle. Um, and so that's what those are the two types that we know of so far. So what causes biliary atresia? I think in those questions that I got beforehand, there's a lot of questions about what caused this and what can be done to prevent it. So the big thing I always tell all of my patients and their families is there was nothing that was done to cause this, and there was nothing you could do to prevent it. And that's absolutely true. I'm not just being nice. It really is. It's a very complicated disease, and we're not totally sure what causes it, but what data we do have suggests it's from a lot of different things coming together in kind of a perfect storm. So the genetics of it are very, very complicated. And what's interesting in identical twins, one baby can have biliary atresia and the other one doesn't. So definitely, that would argue against there being a clear like genetic cause. Um, there are hypotheses or ideas out there that there's probably an injury to those tubes at the bile ducts that carry that bile out of the liver, and then the body just doesn't heal properly. And then in that neonatal period where everything's kind of growing and developing, improper healing causes a vicious cycle leading to the scarring and the obliteration of the bile ducts. There's probably some environmental influence because there are very different rates of this condition in different parts of the world. I believe it's in the in the Inuit native population in Canada. This is a very rare condition. It's 1 in 20 to 1 in 25,000 patients. In the United States and Western Europe, as I mentioned, more common, but only 1 in 10,000 to 1 in like 12,000 patients. Versus in the countries of East Asia, particularly China, Taiwan, this condition can happen in 1 of every 3 to 5,000 births. So very different rates, and would suggest that there's some environmental influence. What that environmental influence is, we still don't know. So this is probably one of the more frustrating parts of this condition, is that we just don't know what's going on, like why it's happening. But there's a lot of really exciting research going on that's uncovering some potential causes. So this is a class. This is actually one of our patients. This is one of our patients, and this is kind of what advanced biliary atresia could look like. And so I pointed out some of the things that can happen. The biggest thing that you notice is this big belly. And this is caused by is fluid in the belly. So when the liver gets really, really sick, blood gets backed up in the abdomen, and then that blood gets filtered through the blood vessels, and the water spills out into the abdomen. So you get these really big bellies. You'll also notice this baby it doesn't maybe look like it because of her IV nutrition that she's getting, but very, very thin legs without a lot of rolls that you would expect from a baby this age. You'll see 2 ways that we are giving this baby food. One is through an NG tube, which is this big arrow pointing up to her face. And the other is a smaller arrow up towards the top. And this is a catheter that goes into her big blood vessels. This is how we give nutrition and are really able to keep kind of the fluids and the salts in her blood just right. Okay. So this is like a classic. This is what babies look like before any sorts of treatment, which, this is pretty, pretty severe. You can see all those blood vessels in her skin. And then you can even see that scar tissue there from her previous surgery, which we're about to talk about. So what are the complications? There are a lot of questions about the complications, and maybe I'll talk more about those in the roundtable. But this is just a list of things that we worry about. So jaundice itself isn't super dangerous, But what can come with jaundice is a lot of itching. Bile, when it gets built up in your blood, is very itchy, and it's a very different kind of itch than like a rash. Feels like you're itching from the inside, is what my patients say. You can also have vitamin deficiencies, particularly the A, D, E, and K. And the reason we have problems with those is because bile is really necessary for absorbing these particular vitamins. With bile is very important in digesting your fats, and so you can lead to nutritional problems. And then also you can have bleeding in your gastrointestinal tract, which is can be very dangerous and life-threatening. Okay. And there's a lot more, but these are the kind of the big ones. And I already talked about ascites. So how are we doing? So as I mentioned, this condition prior to any treatment 60, 70 years ago this was a universally fatal disease. So we're doing better than that. But I don't know, I would argue that we're not necessarily doing well. There really haven't been new treatments developed in the past 60 or 70 years since the development of a surgical procedure to treat this condition. So I would say we're doing better, but I think we definitely have a long ways to go. So what is the treatment? The treatment is a surgery, and I call it a surgical palliation. And the reason I use that word palliation is because it's not a cure. What palliative surgeries do is they make the condition better, but they do, or they alleviate symptoms, but they don't cure the disease. And so what happens is this liver here doesn't have the bile ducts that were coming out. And what you do is you actually cut the intestines and bring up the intestines to the liver. When they come up to the liver, they attach it to the bile ducts that are still there, and the hope is that the bile ducts will then start pouring their bile out of the liver and into this directly attached intestine. So that's why it's called a hepatoporto. So the hepato liver, porto is the portal area of the liver, which is this center part, and enterostomy. So entero meaning intestines, and ostomy just meaning whole, so connecting. So it's a liver. It's the center of the liver connected to the intestines. As I mentioned, so Dr. Kasai developed this in the 50s and the 60s, so a long, long time ago, and we really haven't moved much past that. There have been some trials with other medicines, with steroids, and they just really haven't shown much promise. So how do kids do after the Kasai? So these are what we call survival graphs. And so the 1.0 means 100% of kids are alive with their what we call native liver, so without the need for a transplant. So they're alive and they didn't need a transplant. And as we go out with time, you can see along the bottom lines it's years. So the first graph is these are two different groups of children from Japan. And as you can see, after the Kasai procedure, there's a pretty quick drop off in the number of kids that are alive with their native liver. About 30% of kids, and I'll talk more about these numbers next. Next slide. So how do kids do is you'll see that 30% there's really no response. So I'm going to kind of go back and forth between these slides. You can see there's a steep drop off, and quickly 30% of kids just they need a liver transplant. 50% will improve, but we really slow down how quickly they're getting worse, but they still progress, and they'll need a transplant before they turn 20. 20% of patients, excuse me, will make it to adulthood, but they still have biliary atresia. So what can we do to make the Kasai procedure better? The biggest thing that we've been able to show is that it's really better if done earlier. So I'm going to go back to these graphs. So the group in red, actually, they got their Kasai procedure really early, so before 60 days of life, while the blue is after 60 days of life. And so you can see that there's a fairly big improvement if the earlier you do this. They further broke this data down to kids who had it before 30 days of life, those who had it at 31 to 45, and then 45 to 60. And what they showed is actually, if you can do this before 30 days of life, your outcomes are much better. And actually, Dr. Sunny Harpavat, who is at Texas Children's Hospital and is a real pioneer in this field, he feels that we could make biliary atresia a non-transplant disease if we could catch kids early enough. I think he's very optimistic, but he's also, as far as biliary atresia goes, he's much more accomplished and probably smarter about this than I am. And so I want to believe him. I'm a little skeptical, but I do think that we can make the Kasai procedure work a lot better. Okay. The other thing is experience of the surgeon. I think one of the things that's hard, especially in the United States, is that we have a very fractured healthcare system, and a lot of we don't really necessarily do, especially in pediatric liver disease, we don't do what we call centers of excellence, where people get sent from all over to one center. And so it's really hard for surgeons necessarily to get enough experience to really do this procedure well. So what do we do when the Kasai, as I say, fails? So it doesn't have the desired outcome of slowing or stopping the progression of disease. So what we do is we move to liver transplant. As I mentioned, 30% of children with biliary atresia will undergo liver transplant before 2 years of age. 80% will have a transplant before they even become adults. As you can see from this graph here, the big green wedge with 33, this is all of the reasons that you can get a liver transplant for kids. And the big green wedge is biliary atresia. You can see it's much bigger than everything else. This 22% is other. So this is a lot of different things. So it's not even close. The next biggest is metabolic disease, and it's, biliary atresia is 3 times as big as that. So it's definitely it's our biggest problem in pediatric transplant. What I always, though, tell my patients is that transplant, while necessary and life-saving, is not a cure for this disease either. We're trading one set of problems, which is biliary atresia that will likely be fatal, for another set of problems, which are the problems that come with liver transplant. Thankfully, our outcomes, particularly at CHLA, are excellent for kids, but they're not, it's not 100% forever that kids live. There are complications. I always tell my patients, it's not a matter of if there's a complication, it's a matter of when. So how can we do better? So I'll go back to talk more about Dr. Harpavat at Texas Children's. And so this is a figure from a paper that he published in 2011. What was really interesting is that he looked at the bilirubin levels in the blood. So when we think about jaundice in babies, there's 2 types of bilirubin. There's a type of bilirubin which is called unconjugated or indirect. And that can be high in babies for all sorts of reasons that are going to go away, and they're generally not dangerous unless they go too high. But then there's the direct or the conjugated bilirubin. And anytime the conjugated bilirubin or the direct bilirubin is high, that's not normal. It's not good, and should always be investigated. And what he showed is that babies who ended up having biliary atresia actually have a direct bilirubin that's high on the first day of life. So immediately after birth, they have this abnormality. As you can see from this top graph, this is the direct bilirubin. It differentiates from normal babies very, very quickly, right? So we can actually capture these patients very quickly. Unfortunately, total bilirubin, the bilirubin that we see a lot, you can see there's a lot more dots over here in this bottom graph, which is total bilirubin, and it's not really that different between the two populations. So, but we do have something that's different called the direct or the conjugated bilirubin. It's high at birth. And so what Dr. Harpavat did is he implemented a screening program in Texas where all babies were screened for a direct bilirubin above 1, and like through a newborn screen. And what he was able to show is that before the screening was initiated, it took 60 days for a patient to get that Kasai surgery. But after the screening program, that dropped drastically to below 30 days. And that, remember that 30 days is our magic cutoff. And so how did that happen? And really what it was, what we found is it reduces the time to referral to a specialist. Because you can see in this graph B here is that it took almost 2 months for babies to be referred to a specialist versus after the screening that dropped to 15 days. The time from going to a specialist to the surgery didn't change during that time. So it really helped us identify what patients need intervention. And what he also showed is that these are two graphs looking at how patients respond. So the C is how patients respond. So going up faster is good. And then panel D is need for transplant after Kasai. And so staying high is good. So in both of these graphs, being at above 1 is good. And so what he showed is that patients had better responses to the Kasai and they needed less transplant, which is just really exciting work that if we are able to find ways to identify patients sooner, maybe we can get them to the surgery before 30 days, and maybe we'll be able to avoid transplant in more kids. So how can we screen? So that picture that I showed you actually came from what is a stool card. And so initially was a physical card that in Taiwan was given to all mothers leaving the newborn nursery. And they were supposed to look at it and compare their baby's poops to it. And if it was ever in 1, 2, or 3, they were supposed to call their pediatrician. This has actually been implemented in a number of places and actually has been shown to improve the referral time to a specialist and improve times to surgery, and actually has been shown to improve outcomes. But I think what would be better is probably implementing this on the newborn screen. So similar to how every baby gets their heel pricked for a number of genetic diseases, you could add a direct bilirubin to that and you implement it in a newborn screen, and that could possibly identify a whole bunch of babies much sooner by probably within the first week of life of babies that are at risk. And then they could get to a specialist very quickly. So but what else can we do? Like, are there treatments? So earlier today, I went to clinicaltrials.gov and I looked for biliary atresia. And so these are there's 4 studies, 3 that are enrolling, 1 that recently completed. And so we're looking at using other medicines, so obeticholic acid and then maralixibat are 2 medicines that I'm familiar with, but then also using what's called GCSF, which is an injection medicine that tends to be more in the oncology field, but it helps parts of your blood, your bone marrow grow faster. And so these are things that are being studied now. The Embark trial has actually closed, and we're just waiting for data to see if these medicines, the maralixibat medicine, is going to help in biliary atresia. So how do these medicines, how does this medicine, the maralixibat medicine, how does it work? It's what's called an ileal bile acid transporter inhibitor. And what happens is in a normal flow of things, bile comes out of your liver, goes into your intestines, and then in the ileum, which is the very last part of your small intestines before it gets to the large intestine, there's the IBAT protein, which kind of is a vacuum and it just sucks all the bile acids out of the intestines and sends them back to the liver. But in biliary atresia, you already have too many bile acids because things aren't working quite right. And so what this does is it sends more bile acids into your large intestines and you literally just poop them out. I've seen it work really well in a couple of other conditions that are similar to biliary atresia, Alagille syndrome and the PFIC diseases. And so we're hopeful that this could help improve outcomes after the Kasai procedure. Okay, so I just quickly want to make this is a very short acknowledgement list, but I wanted to thank Dr. Coley, who's currently my supervisor and also a mentor. He's really been helping me with some career development. And then Dr. Cara Mack, she is currently the division chief of GI and liver at Children's Hospital, Wisconsin, but she was my mentor in Colorado when I was there, really taught me a lot. And then to the patients and families that have allowed me to, the honored me with being part of their care, and then the Liver Health Foundation for inviting me today. And then I just want to share one more picture. This is the same child that I showed earlier today. This is after transplant. You can see her. I wish I could show you her face, but I can't. But her belly is much, much smaller. She's got nice, healthy legs now. She's so happy, and she's doing so very well. So that's it, and I'll stop sharing my screen now.
Thank you so much, Dr. Hazelton. This was a very detailed and informative presentation. Before we get into roundtable, I have a question for you. How old was the baby when she had her transplant?
Oh goodness, she was probably 7 or 8 months old.
Yeah, okay, yeah. We will talk now more. We will start the second half of the webinar, which is our roundtable conversation with our experts, that they will talk about their experiences. And also, if you have any questions, please feel free to post it on Q&A or chat, and we will respond. It is my pleasure now to introduce Dr. Jaslan Singh, MD. Dr. Singh is the Assistant Professor of Medicine at the University of California, Los Angeles. She graduated from Washington University, St. Louis, after which she dedicated 1 year to City Year, which is an AmeriCorps program. It's focused on tutoring and mentoring high school students in schools with low graduation rates. She graduated from the Ohio State University College of Medicine and completed her internal medicine residency and gastroenterology fellowship at Loyola University Medical Center. She finished her training in transplant hepatology at the University of Southern California. Dr. Singh has been involved in clinical research in alcohol-related liver disease and hepatocellular carcinoma. She treats a spectrum of liver disease and cares for patients after liver transplantation. She is board certified in internal medicine and gastroenterology. We are grateful that Dr. Singh is a member of the Liver Health Foundation's Medical Advisory Council. Welcome, Dr. Singh. Thank you so much for your support.
Thank you, Farah, for having me.
Sure. We are very grateful that you are always helping us. Over the past few days, I had received several questions that I had sent them to both Dr. Hazelton and Dr. Singh. And now we are going to go over some of those questions that were not responded to during the presentation, or that the doctors want to kind of elaborate on them, understanding that Dr. Hazelton will talk about BA in infants, children, and Dr. Singh has dealt with the people who have had BA and perhaps Kasai procedure and are adults now. So to start the conversation, and I know Dr. Hazelton, you've answered that questions. Are there anything else you want to add to this question that says, are there any medical trials being conducted? And you went through them, you just showed us the list. Are there any ethical challenges to any of these medical trials? Dr.
Yeah, there's always ethical. I mean, one of the big problems we have in pediatrics is that people are very hesitant to do clinical trials in children. And so a lot of times we have to wait for medicines to get approved in adults. But with diseases like biliary atresia, which happen in children first, it's much more like we can't wait for adults trials to happen. So I think I don't know if that's not necessarily ethical challenges, but it's more of a logistical challenge that we have with a lot of medicines, is that getting them approved in kids is harder. That said, the maralexabat and then a related compound odevixibat were both actually first approved in kids, and now they're actually moving into trials in adults for various conditions. So it does seem like perhaps it's changing, but it's very slow to get medicines approved in kids. But as far as specific ethical challenges with with biliary atresia, none that are special for BA that wouldn't be present in any childhood disease.
Dr. Singh, do you want to add anything?
No, I don't. I think, from an adult perspective, I think not there aren't too many people that end up to us without a liver transplant. I've had just like a couple of patients who I've been seeing actually for the need for liver transplant, in adulthood, patients who are in their 20s or 30s. But for the most part, I would say my experience is with transplant recipients, who have transitioned from pediatric transplant care to adult care.
That's a good, I have that question about that, but I want to go back to what Dr. Hazelton was talking about screening the babies for BA. Is this happening in the United States only maybe in children who are born with jaundice, or we're not doing that screening?
Yeah, we're not really, it's not consistent. There is, how to say this without throwing anybody under the bus. I think there's resistance from institutions like state governments and the people that the institutions that do newborn screening, because there's you don't want to identify, how to say this, you don't necessarily, like, if there's no follow-up that's protocolized, that where if a baby's identified, they need to get to a specialist right away. And so that network, I think, has to be built first. And so that network hasn't been built, and so it's an advocacy, I think, at the advocacy stage now. I think we need to, people, if there's people on the webinar want to push their elected representatives or advocate through things like the Liver Health Foundation to try and encourage states to implement a direct bilirubin screen at birth, that would be great.
Is that the same thing with the stool card? We don't give parents a stool
Yeah, we
card.
don't. I think that's a little bit more. I think that's a little bit harder, just as far as it, because you're putting some of the work onto the parents, and as if have ever had a newborn, it's a lot to just keep another creature alive, and so asking them then to also have this card and keep a close eye on it, it's a lot when we could just do a pretty quick blood test to identify.
We have among our patients, we have some patients who received transplant when they were really tiny, few weeks old, few months old. And then we have others who are now in their 16, 17 years old and still have their native liver. And they did have Kasai procedures, and it has been successful. We had one patient that didn't even need a liver transplant until after high school. He was working and grown up, and then all of a sudden had to have the liver transplant. His liver failed. The other person we have is a 16-year-old, very vivacious, very active young lady. Kasai procedure went well. She has her native liver. So the questions that these parents of these two have asked is there anything in common between these kids that have their native, had Kasai and have a native, and went into their adulthood, and those who need transplant earlier, even after successful Kasai? What is the equation? What is different between the one who go to adulthood and the ones who have to have it 5, 6 years old?
I mean, that's the question. And I don't know that I'll be honest, like, I don't think we know. some I think it's how early they got their procedure. The earlier you get your procedure, the better you do. And so I think that's one thing. I think that other than that, like it's really hard to say. Some kids get a lot of infections in their liver after the Kasai procedure, and that doesn't help them. Um, it's really hard to say.
Yeah. Yeah, the parents are confused when they see somebody who is in adulthood and haven't had liver transplant, and their little kid had to have transplant. Dr. Singh, when you are working with adults who are getting ready for transplant, um, what do you see? Are they normal growth after Kasai and after living with their native liver for a long time? Do they have normal growth? Everything is okay. What do you see when you are treating those patients?
Yeah, I think, for the most part, they look okay. I think that's why they've been able to make it to adulthood without the transplant. Because if they were really sick from a liver perspective, they would have been transplanted at some point before that. So I think, for adults, similar to what, Dr. Hazelton was saying about the infections, some patients can develop these recurrent infections in the bile ducts. And, so they actually, look okay periodically, but if they keep, going into the hospital with these types of infections and ultimately, need for liver transplant, then I think they look a little bit different than probably when they presented as a child. But I would say that they're not, when they come, they may not necessarily be very, very sick. But the bile ducts, like the inside of the liver, tend to be, a recurrent issue for them.
Yes, I've heard about the infections that parent had to keep going to hospital because of the infection. And what is it, the equation there that most of those when liver fails, the kidney also fails. But we have had patients that had to have both liver transplant and kidney transplant at the same time.
Yeah, I mean, I think that's that could be related to, multiple reasons. If it's related to the liver, then it's just because of the pressure around the liver, which we call portal hypertension, can sometimes negatively impact the kidneys, in which case then patients may need a liver kidney. Sometimes people may have other reasons that their kidneys are failing at the same time that their liver is failing. And that may be another indication for a liver and a kidney transplant.
Yeah, okay. I'm going to read a comment and a question. So either of you please respond. She says, my son was born with biliary atresia in 1985, had the Kasai procedure at 8 weeks, and first liver transplant at age 2. Second transplant at age 20 due to Hep C and chronic rejection. How have treatments changed since then? Trial drugs were used on him, including, I think it's Prograf.
Yeah,
Basic,
it's tacrolimus.
yeah. She says she would like to know how the evolution of treatment has happened, or whether there is any evolution in their treatment. She said, my son is no longer with us. He passed away 4 years ago, needing kidney and liver transplant. So you talked about the Kasai was developed 60 years ago.
Yep.
How has that procedure improved? And are you still using the same original procedure?
So I don't actually do that procedure, so I'm not I'm not a surgeon, so I don't want to comment too much on that. Just because I don't know. It's not something that I do. I think the more you do the procedure, the better you get at it. My understanding is it hasn't really changed, but I wouldn't be I wouldn't be truthful if I said that with any sort of confidence. But really, I think the overall is that treatment for biliary atresia really hasn't changed too much, and except for that, I think we're much more aggressive with nutrition over the last 20 to 25 years. Even since I've been in training, we've become much more willing to put the IV nutrition in sooner, just to really make sure that babies are as nutritionally replete as possible. We use specialty formulas that can help now too. But I don't it it the big treatment really hasn't changed.
Okay. And the other question is, do you recommend genetic counseling for me to learn more about my baby's condition?
Yeah,
Does genetic counseling help?
unfortunately, no. If your baby has the biliary atresia with splenic malformations, genetic counseling could be useful. There are some genetic changes that have been associated with that special type of biliary atresia, but just with regular isolated biliary atresia, unfortunately, genetic counseling won't help. I actually just had this conversation with a family this morning in clinic, and I think and I don't know if Dr. Singh has a similar experience, but I found that really broad genetic testing for these conditions that don't have a clear cause can actually cause more stress, because genetic testing is able to test for more things than we have knowledge about. And so you end up with what are called these variants of unknown significance. Um, and we don't know what they mean yet, because our knowledge isn't quite keeping up with our ability to test. And so then people see these changes and we don't know if they're good or bad. And so then you just worry about them. So I don't think that since we don't have clear causes for it yet, I don't think it's useful. If your baby has the splenic malformations, then yes, I think that would be useful. But I think for regular biliary atresia, not useful.
And the other question is, please talk more about complication of biliary atresia for you, Dr. Hazelton, and then I want to ask the same thing from Dr. Singh, what she sees when they're adults and come for liver transplant. So you mentioned some of the complications. Would you expand on that, please?
Yeah, so I think before the Kasai procedure, the biggest thing is the portal hypertension, that buildup in pressure that Dr. Singh talked about, and that can just cause all sorts of problems. It can cause it causes the blood has to get, so basically what happens is the blood coming from the intestines can't go through the liver, and so just like traffic in Los Angeles, it finds a way, and because it has to get back to the heart somehow. And unfortunately, sometimes the path that it chooses is a very fragile blood vessel that's in your feeding tube, the esophagus. Those fragile blood vessels can burst. I think that's the thing we worry about the most as far as like scary things. The kidney disease that we mentioned, you can also get lung problems from your liver being sick. Something's called hepatopulmonary syndrome or portal pulmonary hypertension, um, which can actually be reasons for needing a transplant just on their own. So those are the big scary things before transplant. Some of those things don't go away if the Kasai was done late or it doesn't work, because your liver stays pretty stiff, and that pressure stays high. The thing that we worry about afterwards is you're taking a piece of intestine and attaching it. So the intestine to the liver, the intestine is not sterile, the liver is sterile. And what can happen is you can get infections that go from the intestines up into the liver, and that can be a pretty serious complication. I think those are and then nutrition. It's always nutrition. Like as a pediatrician, our jobs are to grow our patients. And when there's diseases that make it hard to grow, that can cause all sorts of problems.
Dr. Singh, what do you see of in the patient that come for transplant as an adult that had Kasai procedure? What kind of side effects or other diseases they may have?
Yeah, actually, very pretty much the same thing that Dr. Hazelton was saying, are complications of the portal hypertension, and then what we call recurrent cholangitis, so getting those infections in the bile ducts. And it sort of mimics some of the adult onset biliary diseases as well, like primary biliary cholangitis or primary sclerosing cholangitis, which can occur in kids as well. And so it's, similar to that where there's sort of this disproportionate pressure around the liver, related to their liver function. So that often is part of their disease progression and need for liver transplant.
Mhm. There is no COSI procedure for life, right? You've got to have transplant some point in your life if you have COSI procedure.
I wouldn't, yeah, I wouldn't say never, but yeah.
So now, how does biliary atresia relate to heart defects?
So that in that biliary atresia with splenic malformations, um, uh, to not try not to get too technical, but what they think happens is so they're on many cells, there are these little hairs that kind of move things into the right place during pregnancy. They're called cilia. And so what we think happens in biliary atresia is that there's problems with cilia, and there's problems with moving things into the right spots. And so when things aren't put into the right spots, it's like putting Legos together without the instructions. And so things might look close, but they're not quite right. And so those in the biliary atresia splenic malformations, you can get congenital heart disease. You can get a variety of different complications. I'm not an expert in those. I generally lean on my cardiology colleagues to help me with that. And then also it's not a common thing that we see. But you can get all sorts of cardiac diseases, and thankfully at places that take care of a lot of biliary atresia, there's usually someone who's very good at heart disease as well, and we work together as a team.
Both you and Dr. Singh, is there a correlation between biliary atresia and your race, gender, or, for example, do Asians have more, or Americans have more BA children, or women, female babies get more, or male? Is there any studies that show us that?
I don't know the answer to that since I'm not seeing a lot of these patients.
I can jump in. Yeah, so it is much more common in East Asian countries, and it's more common in Asian Americans. We don't know particularly why. And there's a lot of conflicting studies regarding gender differences. But we don't like there's clearly something different between East Asian countries and other places in the world where it's much more common there. What that difference is, we don't know yet.
So maybe there are environmental factors?
That's what the thought is, but we haven't been able to identify them.
Yeah. Dr. Singh, what are the ages you see for liver transplant that are BA babies, had been BA babies?
What do you mean, like how old the adults are that are
Right,
undergoing
right,
transplant
right.
evaluation? Again, just a couple of patients, so not a ton that I have. I would say like they're both in like their 20s, early 30s.
Yeah, that's what I hear. We had a BA seminar that I had attended, and it was very interesting to see that most BA children that have grown up to be adults had required transplant at about 20, 21 years old. And but we had a couple that were in their 30s. Actually, one woman that was in her 30s, and she had 2 babies already. And she still had the native liver, her native liver, and she was still living with the Kasai procedure, and she was fine. She looked all right. Coloring was good. Her features were great. No issues that I could see with my untrained eyes. So one of the things that I know a lot of our patients are worried about, especially parents, is that how long my child can go on without being forced to have liver transplantation. That I know depends, right? You can't tell for sure who is going to need it and when.
Yeah, I mean, if if your bilirubin after Kasai falls to below 2 by 3 months, that's our best signal that things are going to last for a while. So how quickly you're able to clear your jaundice, it can help us predict, but there's always, it's not 100%.
Dr. Singh, what do you see when you are working with transplant patients? What are the main causes for transplantation? The younger generation, like 20 above, is that BA? That's the cause? You said you have had some experience with that.
Yeah, I would say that the biliary atresia patients that I see they were transplanted as young children, as babies for the most part. So I'm not seeing a lot of patients that were transplanted in adulthood. So they're mostly a transition from pediatric liver transplant care to adult transplant care, and that's how we come to be a part of their care team.
And the lady that I read her note that asked if the procedure is still the same as it was used originally, her son had to have 2 liver transplants before he got to be 20 years old. So it is a big issue for parents. I hear a lot from parents who have biliary atresia children, and the fear is that if one child has it, and if I have another kid, is he or she going to have biliary atresia as well? So there are many issues that parents worry about when they have one child that has biliary atresia.
Yeah.
But
In general, for anyone that's on the call that maybe has that worry, I don't think the data really would bear that out. And most of our families that have kids after having a kid with biliary atresia, I haven't ever seen siblings with biliary atresia. So I think that's, and I mentioned, and there are identical twins where one has it and the other doesn't. So it's not a clear genetic cause. And I think having that worry is totally normal and totally understandable, but it shouldn't hold you back from having more children. Having to take care of a complex child is hard, and adding another child on top of that, that's a different discussion. But I think it's unlikely, I won't say never, but it's very unlikely you would have a second child with biliary atresia.
thank you. Thank you, Dr. Hazelton and Dr. Singh. We are grateful for our excellent guests. This was a great educational webinar. We hope everyone got answers to their questions and learned more about biliary atresia. I need to let our audience know that our presenters are here as volunteer physicians. They care deeply about liver patients, about you. They use their own personal and family time to come here and attend these webinars and share their information, their expertise with all of you in support of our efforts in helping liver patients and raising awareness of liver disease. My personal heartfelt appreciation to our doctors for their kindness and compassion always. Thank you, Dr. Hazelton, for a wonderful presentation. We are grateful and look forward to many years of partnering with you. Thank you, Dr. Singh. Liver Health Foundation is grateful for your continued support. Thank you. And thank you, Epson Pharmaceuticals. We appreciate your support of our efforts in educating liver patients and the community. Liver Health Foundation will host a webinar on Alagille syndrome on August 21st from 5:30 to 6:30 p.m. Pacific time. The speaker is Dr. Coley from Children's Hospital, Los Angeles. Please register on our website to attend this webinar. We will also host a webinar on primary biliary cholangitis, or PBC, and primary sclerosing cholangitis, PSC, on September 10th from 5:30 to 6:30 p.m. again Pacific time. The speaker for that webinar is Dr. Walid Ayub from Cedars-Sinai. Again, please visit our website so you can register and attend the webinar. We are on all social media, so please check us out. And we put all of our information, our news on social media, so please visit us. Thank you for joining us this evening for this important webinar. We wish you a happy and safe summer. Be well, take care until we meet again in August. Thank you and good night.